Hello, ladies and gentlemen. Thanks for the opportunity to have a talk here. My name is Jakub Řezáč. I'm a urologist from Prague, and this presentation is about the main causes of male infertility. As I'm the only urologist in this conference, it would be a urologist perspective on male infertility. As you all know, male infertility associated factor is present in up to 50% of cases. A pure male factor in the latest data is set about 20%, but it depends on the literature you look at. Definitely, in all infertile couples, a male should undergo a medical investigation. You all know that female age is often talked about as a big risk factor. Newer data shows that also paternal age is a risk factor of male infertility. Etiology is very wide. Of course, it could be congenital and acquired urological abnormalities of any kind. It could be any genetic abnormalities. Varicocele, I will talk a bit about varicocele later, which is often thought about increased growth of temperature, but maybe that's not everything that varicocele causes. Any urological tract infections previously, such as STDs, some endocrine disturbances, immunological factors, iatrogenic factors such as previous growth surgeries, could be varicocele as well, sadly. Any malignancies in the testicles, especially, and some gonadotoxic exposures, such as after some other malignancies, so from radio and chemotherapy. Sadly, even though there are plenty of things that can cause male infertility, there are still almost 40% of cases called idiopathic male infertility, when we really don't know the real cause of the problem. It could be from pollution, it could be from some social factors, maybe it would be from some oxidative stress factors and DNA fragmentation as well. Maybe the scientific community will help us in the future. Of course, the main investigation is the semen analysis. You all know that oligospermia is under 60 million sperm in 1 milliliter, astenosospermia less than 32 of progressively motile sperm, and teratosospermia less than 4% of normal forms. There are some other tests that we can do, such as measurement of oxidative stress. I know it's, again, widely talked. There are several ways of measurement. From 2024 EAU, European Association of Urology Guidelines, which we are usually looking at for our treatments, says that still we don't have sufficient data, and there is no one best way of, or one main way of measuring oxidative stress, and it's mainly done still in the scientific background. Another thing which is more widely used would be measurement of DNA fragmentation. We know that over 25% causes worsening in the nature of spontaneous conception and from IUI, and then over 50% even poor outcomes from IVF. Maybe you have different data from your literature. This is again from mainly EAU and from urological point of view. Our data says that even that in higher DNA fragmentation, maybe there would be a reason to do a TESE as well, as testicular sperm for ICSI is associated maybe with possibly improved outcomes compared to normal ejaculated sperm with that high DNA fragmentation, especially over 50%. Imaging mainly would be a scrotal ultrasound, where we measure volume of the testicle, of course the anatomy, any signs of obstructions. That could be mainly some dilatations in the right testis, where the canals go to epididymis, enlarged epididymis as well. We all know that from, for example, vasectomy, then the epididymis gets enlarged afterwards. And the same could be done if the obstruction is not done by a surgeon, but by some other factors. Some cystic lesions, and of course, absent vas deferens. Then tumors, mainly tumors are usually quickly growing and palpable, but it's not the case in all the tumors. Varicocele and even though the compliance of the patient is usually pretty low, from our data, transrectal ultrasound would be advised, especially to see the seminal vesicles. So if there's any obstruction, usually they get enlarged. Sometimes they could be absent, again from some genetic reasons. We'll get to that later. And thankfully, most of this can be done via normal abdominal ultrasound as well. So when there's some amount of urine in the bladder, we can see through the bladder window on the prostate, and then see usually pretty well the seminal vesicles as well. But it's not as good as with transrectal ultrasound, which would be more used for some prostate biopsies and so on in urological practice. This is a typical picture from ultrasound. So normal testis, normal same echogenital, and for example, if there will be some tumorous lesion, it would be hypoechogenic with more blood flow. Genetic testing, it should be done in every man with azoospermia. That was my practice. Our literature says that it should be done in all the men with oligozoospermia as well. I'm not sure whether it's really done in every facility. And basically, it's karyotype, cystic fibrosis, gene mutations, and Y chromosome microdeletions. From the karyotype, especially some chromosomal abnormalities, most typical one would be Klinefelter syndrome or mosaic of Klinefelter syndrome, where in almost 50% cases, even in Klinefelters, if you put mosaics in there as well, would be successful. So even a person with Klinefelter syndrome is not excluded for potential treatment. Cystic fibrosis, that would be the absence of vas deferens, of seminal vesicle. You would think it's not, of course it's not common, but just 2 weeks ago I had a patient who had cystic fibrosis. He had no other signs, none at all, so nothing with his lungs, nothing with breathing. And I found on the examination that he had no vas deferens, so it would be just obstruct azoospermia. Y microdeletions, we can see the Y chromosome here. So it's F, A, B, and C. Especially A and B regions have very bad or poor prognosis for retrieving sperm from TC. So again, it's the only option we have for the patient. We can still do it, but the patient should be well informed that the chances are pretty low. Hormonal testing, that would be the next thing that we would do in our practice. FSA, LH, prolactin, thyroid stimulating hormone, of course, testosterone, and sex hormone binding globulin. If it's possible, then free testosterone, but we can calculate it from albumin and sex hormone binding globulin. PSA, even though it's usually advised from 45 to or 50 years old, we still do it, especially if we later prescribe any hormonal treatment that could prove problematic, because then if the PSA is rising, maybe there's some risk of prostate cancer. Of course, we are not doing genetic mutations for BRCA1 and 2 in these patients. For the tumors in the testicle, we do beta-HCG, alpha-fetoprotein, and lactate dehydrogenase, and especially in obese patients, estradiol would be advised as well. If you later plan to prescribe any hormonal treatment, we need to do a blood count. Hematocrit over 54% would be a big no for any hormonal treatment, because patient can have some cardiovascular problems later. And of course, liver and kidney function, also because of the testosterone. Let's get to some of the diseases that we can see. One of the risk factors for infertility is testicular dysgenesis from cryptorchidism. We know that paternity in male with just one side cryptorchidism, one non-descended testicle, is almost equal to men without it, but especially bilateral cryptorchidism reduces chances of paternity. Another problem about non-descended testicle is a bigger risk of cancer. So especially if it's intra-abdominal and non-palpable, the patients are definitely advised to have orchiectomy even in later age. And orchiopexy may be advised, especially in men, even in later age, in males with hypogonadism or infertility. The chances of the testicle working well and making some sperm is not very big, but for testosterone there are chances, and maybe with this treatment they will not need some replacement therapy. As far as varicocele, again, it's very common disease. One of the biggest mistakes we did as urologists was to treat almost all the cases, which is definitely in these days shown as over-treatment. It's not necessary. And so 15% of male population have it. Is the same disease as varices on lower limbs, the same disease as the hemorrhoids. So just enlarged veins going from the testicle. Almost 25% with varicocele may have abnormal semen analysis, but this may not be a totally correct number because it's from the data and it's very difficult to have a proper one. There are very few RCTs or randomized control trials done in andrology, and we still really need to do more research. In 35 to 40% of men, they are presenting with infertility. And when you have just some subclinical varicocele, where we can see on good ultrasound on Doppler that there is some reflux of the blood in the Valsalva manure, also that has much different outcome than male with some third degree varicocele with really huge veins, which may definitely cause worsening of the sperm parameters. The exact association which does it, which causes infertility in varicocele is unknown. In the past, mostly it was talked about the testicle being in different temperature or higher temperature than it's supposed to be, but nowadays there is bigger talk about the oxidative stress on the testicle and bigger volume of blood pushing down and lowering the blood flow inside the testicle, which may prove as the real reason for infertility in these men. So increased scrotal temperature, some hypoxia caused from this reflux, and that may everything in many years of these problems may cause dysfunction and infertility and DNA damage. We know that after varicocele repair surgery, there is in patients who had DNA fragmentation before, usually it's better afterwards. But again, it's just small trials. As far as varicocele repair surgery, I'm a urologist, so this is big letters, and this is just small letters because sclerotization would be done by an angiologist or radiologist. So they are going against us, but they are definitely, I use them a lot in my practice because there are plenty of patients who for example, after previous varicocele repair surgery, sclerotization may help. Also in patients with bilateral varicocele, it's a really long procedure with long anesthesia, and sclerotization can be an ambulatory procedure. The radiologist would just put some glue inside the veins going from the testicle. So, as I said before, there is a risk of over-treatment in adolescents. In our practice, usually only children who are not having the correct size of the testicles growing up would be candidates for the surgery. In our hospital, in children, it's still done laparoscopically, but in adults, usually done by a micro-subinguinal approach. So just tiny, maybe 2-3 centimeter incision on the inguinal canal, on the annulus inguinalis superficialis, and through that we get to the spermatic cord, and under some microscopic enlargement, we see the enlarged veins. We can see lymph vessels, which we are trying to preserve with this approach, and of course, we are trying to save the testicular artery and of course the vas. By repair, you can definitely increase sperm parameters, but even in this, which would, I think most doctors would think that after decades of this surgery, the data would be sufficient. Still, no randomized controlled trials or not enough available. As I said, it reduces the DNA fragmentation and definitely may improve outcomes from assisted reproductive techniques. Non-invasive male infertility management, definitely the main thing and the thing that the patients are fighting the most is to change their lifestyle factors, which definitely may help. So obesity, low physical activity, smoking, alcohol intake, those are sadly typical things for Czech men, and they are definitely associated with decreased sperm quality. As far as antioxidant treatment, it's widely done. We do it in most patients. There is no big reason not to do it. But from our data, there are really no conclusive data that it helps. Our guidelines say it may improve sperm parameters. Again, no sufficient data. Hormonal treatment. Definitely secondary hypogonadism can be treated by HCG FSH. Usually it takes for a long time. HCG is used more widely as 2 times weekly injections. But again, in normal clinical practice, mostly we use selective estrogen receptor modulators such as clomiphene or aromatase inhibitors such as anastrozole. As I showed on the previous or a couple of pictures back, we also look for prolactin. So in hyperprolactinemia, if the levels are high, we do first of all another test, because for testosterone we need morning test. For prolactin, usually it's better if it's done around noon, because there is some portion of population that have higher prolactin in the morning naturally. But if it still stays higher in lower levels, we would start with treatment with dopamine agonists. In higher levels, we definitely should do MRI to exclude any pituitary adenoma or send the patient directly to endocrinologist. Testosterone therapy is, of course, completely contraindicated in infertile men. That would be a treatment for late onset hypogonadism. Now let's get to the thing that you all know that we help you with, which will be some ways of sperm retrieval. These are a couple of them: aspiration through the skin, test TC more widely done, or aspiration from the epididymis. And usually there are two options of treating. One is for obstructive azoospermia, one would be for non-obstructive. For obstruction, we can see in these patients that usually they have bigger epididymis, normal testes, normal hormonal levels, and that can be caused by genetics, cystic fibrosis, iatrogenic, vasectomy, or some other procedures done previous on the testicle and the cord, by some traumas, by infections, especially STDs. And in patients after vasectomy, we can definitely do recanalization, but even when we use microscopic techniques, still the rate of successful surgeries is only about 50% of cases, especially when it's longer time after vasectomy. It doesn't really work because some other part of the cord of the vas can get obstructed, and we are usually not able to get there. Interesting procedure is when there's ejaculatory duct obstruction, we can do transferator resection of the duct, which again may help. We have patients who had this procedure several times, and the reason is that sometimes it gets obstructed again, but definitely that's one of the possibilities. But even in patients with obstruction, there are definitely, they may be still indicated for TC or to do MISA, because that will be most likely successful. And if you compare the surgeries, the TC is definitely smaller one with lower risks. When we do transferator resection, we are close to the sphincter, even though it's unlikely the patient may end up with some form of incontinence. And for non-obstructive azoospermia, in the past, or there are still data and some new works on finding the aspiration mapping. That would be a technique where they do several injections in the testicle and check for the zones where you have bigger amount of sperm. But that would be just for later surgery, maybe to have slightly better outcome from TC. Nowadays, especially when the microscopic techniques are widely available, it's not really suggested suggest it to the patient because that would be another anesthesia, another procedure with some other risks. And there is really no reason to do it at this point, even though I had patients who asked for it, and I had patients who had this procedure in different facilities. Testicular sperm aspiration would sound very good. It would be just through the skin, just under local anesthesia, and there are definitely patients asking for it. I don't know about any facility that does it in Czech Republic. From the data, it's not recommended because the rate of successful surgery was much lower from available studies, and because we don't have any possibility to see the testicle and to see the areas under the skin, and ultrasound is not really sufficient in this area, there is slightly enlarged risk of some bleeding afterwards. So the most recommended ones would be TC and MISA and micro-TESE. Micro-TESE you probably know, but it's not micro in this case wouldn't be a smaller surgery. It's actually a bigger one. In typical MISA TESE, nowadays we do mostly mini TESA MISA, where you don't take the testicle from the scrotum, so just about 1 centimeter incision, which makes it slightly more complicated for the surgeon, but definitely improvement for the patient because maybe it's 2 stitches on the skin, and the rate of success is similar. For micro-TESE, that would be if this procedure is not successful, we continue this way. There are two ways doing it. One, the maybe older, would be to do several cuts on the testicle and trying to find part of the testicle which may prove better, and when we see maybe better canals in the testicle. Nowadays, it's mostly done via bigger incision in the equatorial line of the testicle. We open the testicle. Maybe it's slightly more difficult to close the wound right afterwards because there's a lot of tissue sticking out, and in this tissue we are trying to find again some zones where there will be a bigger chance of finding viable sperm. Okay, so thank you for attention.